This lecture is going to turn on its head a lot of what you may have heard about how important it is to optimize the thyroid. And this is a topic that not only gives functional medicine doctors a black eye, but conventional medicine doctors a black eye. This will be helpful for everyone in the audience to see what's going wrong and to be able to spot it in your patients so that we can do a better job avoiding harm, because I think I'm seeing a ton of MDs really screw this up, and I don't want to see it anymore. So the big problem that we are seeing is that the number of patients who are getting prescribed thyroid hormone prescriptions has skyrocketed. I'll show you how many in the next slide. But the idea here is that there's this growing theory that if we just optimize the thyroid hormones, that all sorts of symptoms will get better. And because of this belief, we're seeing more and more people who don't have hypothyroidism getting medications inappropriately. And patients are coming away from their clinical visits saying, oh man, yeah, the doctor said I have low thyroid, and so I need this medication. And then they're staying on this medication for the rest of their life. And this just is not a helpful paradigm. It doesn't help patients heal, and it often just makes people worse. So that's what I'm going to try to convince you about in today's lecture. So we know that thyroid prescriptions have gone up by 30% in the last decade. And so is the question, do we really believe that hypothyroidism has become 30% more common? I think that that's a pretty hard argument to swallow. And this paper is going to say, a good practice would be, simply repeating the TSH levels 2 months after you have an abnormal. I think that would be something that would help quite a bit. But 30% is a quite big number. And so let's just do a very basic high level, what the heck are we talking about with thyroid hormones? So the thyroid gland is producing two active hormones, T3 and T4, and it also has the ability to convert T3 back and forth into T4, T3 being the hormone that does the vast amount of the metabolic work at the cellular level. So we think of T4 more as the storage form and the T3 being the active form, right? So the body will make a certain amount of these, but it will make a decent amount more of T4. And then when the body needs the T3, it will convert the T4 to the T3. The other big player that's so important that I'll talk a lot about is the TSH. And the TSH is the brain's central command way of telling the thyroid how hard to work. So if it's putting out just small amounts of thyroid, of TSH, it's also called thyrotropin, right? Thyrotropin being a growth, they're trying to stimulate the production of more hormone. If it's sending just a small amount of thyrotropin, TSH, it's because it doesn't have a huge need for a thyroid hormone, or it's seeing too much. So low levels of TSH would be a normal functioning thyroid in most cases. When the TSH rises, it's like the brain is shouting at the thyroid, hey, make more hormone. And in a lot of cases, the brain says, oh, we need a little bit more. It can turn the volume of the TSH up and get enough T3 and T4 output. Everything is fine. When this environmental crisis or exposure or issue in the gut has receded, the TSH will drop normally and return to normal. So what's happening is a lot of doctors are seeing that temporary spike in TSH and they're saying, oh no, the thyroid isn't working well. Meanwhile, that they are really neglecting the fact that the T3 and T4 hormones may be completely normal. There is, of course, a big feedback where the T3 and T4 hormones then send a signal back to the brain, particularly the pituitary, to say how much TSH to make, right? So when the T3 and T4 levels go up, the brain gets a signal, okay, we don't need to make any more TSH. So just to put some numbers and some into a chart here, we've got a couple main types of thyroid diseases, right? We have subclinical hypothyroid, and this is the condition in which I'm seeing the most amount of inappropriate thyroid prescriptions. And a TSH between 5 and 10, so slightly above the normal, with normal T3 and T4 is kind of like a warning sign that, the body's having to work harder. And if this were to stay in a subclinical state for years, it might progress later to true hypothyroid. And true hypothyroid would be when the TSH is elevated, but the thyroid is not responding to that stimulus to make more 3 and 4. The opposite of true hypothyroid, low thyroid, would be hyper, right? So in this case, the thyroid is mistakenly producing too many hormones, too much T3 and T4, and as a result of that feedback that we saw, the TSH is suppressed. So we see a very, very low TSH when we have high T3 and T4, and that would give us a diagnosis of hyperthyroid. Hashimoto's is the most common autoimmune disease found in the human body. And this is when the autoimmune system is making antibodies, TP, thyroperoxidase, and thyroglobulin against the thyroid gland. And that causes inflammation. In a classic case of Hashimoto's, we will see at first a spike of T3 and T4, and then over time, hypothyroid. So it's usually diagnosed here when the T3 and the T4 are low, but initially that inflammation may cause kind of a pseudo hyperthyroidism. So it can be a little bit tricky. So Hashimoto's can be bimodal here is what I'm trying to say. Graves' disease is a different antibody. And this, of course, is causing typically a hyperthyroid type symptom. But we can see a lot of variation in the hormones with Graves'. And meaningfully, we want to check a different subset of antibodies. So just a very high level overview of things that can go wrong in our favorite gland. In my practice, these are the things that cause autoimmune thyroid conditions. These are the things that I've been able to treat and see antibodies go down, or I've seen someone, for example, exposed to a new toxin and develop autoimmunity, particularly the TPO. And so GI problems, SIBO, SIFO, irritable bowel, inflammatory bowel disease, or just run-of-the-mill dysbiosis. I've seen drive Hashimoto's. The other major culprit is mold. So exposure to mycotoxins is really a big one. And I've seen several cases where someone moves into a water damaged building and 6 months later, they have new onset autoimmune disease. So we really want to be cognizant of our environmental exposures. And the other two would be high amount of plastic and heavy metals. We have good evidence here that those things can do it as much. It's harder for me to pin the heavy metals and plastics directly on the onset of autoimmune thyroiditis because these are low doses over time. So very rarely do we see a huge enough exposure that we would see it, but the literature is really, really pointing in this direction, and I would really want to keep that on your radar. Okay, so let's get into the meat of my argument that I think people are getting way too many thyroid hormone prescriptions and it's hurting them. So in 2021, Jeff's favorite journal, JAMA, looked at 60,000 patients. And they wanted to see, based on labs, who is getting medication. And only 8% had true hypothyroidism. This is what it looks like. So this is pulled from my clinic, a TSH of 125 and a free 4 low. TSH is screaming at the thyroid, make hormones. And the thyroid's like, no, I'm tired. I can't. Right? That's true hypothyroid. This person will feel a minimum 50% better with a single pill of levothyroxine. Right? It's like, boom, this is root cause. You fix a non-existent thyroid hormone level with a thyroid hormone, and someone will dramatically improve very quickly. And there's no question in my mind that something like this would need a hormone. 61%, however, had normal T4 and T3 levels. They were not hormone deficient. They just had a bump in the TSH and they were given hormones. So they have normal hormone levels, but they're being given extra. That's really what that means. And you may say, okay, well, it's within a normal range, Dr. Joe, but maybe this person just needs more, or maybe their range is not good. But what this comes down to, and we'll get to this later, but what this comes down to is that it's a hypothesis. It's a hypothesis. We can say, oh, okay, well, we think the range should be this. And let's see, even though they only have slightly low T3 or they have normal T3 and T4, I think it should be level X, Y, or Z. So let's give it anyways and find out. What I want you to know is that the overwhelming majority of studies that have looked at giving thyroid hormones, T3, T4, Armour, and Synthroid, have not shown benefit in this condition. So no improvement in quality of life or brain fog or fatigue or GI symptoms or weight loss. It doesn't work. So 61% of people are getting a prescription that's very unlikely to help them and more likely to hurt them. And freaking a third have normal thyroid function. What are we doing? Right? 90%? Right? They're 90% getting prescriptions they don't need. Let's say, and let's be generous, let's say 10% of these actually needed it. 80% are getting hormones when they don't need it. It's ridiculous. So here is this idea that's crept into functional medicine and it's just become a truth, although it's a lie. There's an idea that if we optimize our levels, that the levels that are put on a blood work are not good enough. But if we optimize the levels, we'll get better outcomes. And some doctors say that TSH should be, you should treat until the TSH is between 1 and 2. Some people have made up something different and they say, I believe it's 0.5 to 1.5. And it's all kind of different. You'll see different scribbles, but this is the first thing that I go, uh-oh, when I see some labs and there's scribbles on the side. So this doctor did not like the range of 2.3 to 3.2, and they decided that the free T3 has to be, I guess, above the 50th percentile. And if it wasn't, then that's low. Please start Armour thyroid. The free T4, in this case, they decided arbitrarily with no evidence that 1.1 was their cutoff, and they want a TSH of 1.2. This patient got worse on Armour thyroid. And every single person would know the name of this doctor, would I to mention it. He's very well known and very popular in the functional medicine world. And this doctor kept giving this patient a variety of thyroid hormones over the course of 2 years. And every single freaking time he did it, they got worse. Anxiety, agitation, insomnia, fatigue, because they were being given a hormone that wasn't needed and was extra. When the body sees hormones it doesn't need, it has to engage cellular processes to protect itself from extra hormone. It makes more binding globulins, albumin, thyroid binding globulin. So you end up mucking things up. Right? So that's what this doctor did, increasing doses until they hit the number, regardless of their response. If this world famous functional medicine doctor had asked the patient once, hey, I gave you that Armour, how did you feel? He would have heard her because she told me I felt worse. This has to stop. It should be malpractice. A lot of these cases really get very, very close to malpractice in my perspective. Here's another one. We'll go through with its case studies, right? You get to see all the crazy shit that comes across my desk. Whenever you see doctors writing in the margins like this, it should be a huge red flag, right? We don't need exclamation points. Why? We don't need sad faces in our labs. This is inappropriate. In this case, 4.779. The range was 4.78. It's not high. I don't give a shit, right? TSH, a TSH is normal in this range. Above 10 is the very beginning at which we can say the TSH is out of range. And I'll show you why. But these are normal ranges. There's no thyroid disease, but this patient was treated for years thinking they had thyroid problems. Okay? It's really inappropriate and it's really scary, right? They're all different ranges that these doctors are deciding they want to see. Here's another one. They have magic beliefs about reverse T3 that are not substantiated, and this stuff is just doing harm. Here is someone who is, I took this from their website. Actually, you know what? This is Isabella Wentz. She's a pharmacologist, so she was not trained to interpret labs. She was not trained to take a history or do a physical. She was not trained in nutrition. She was not trained in clinical medicine in any degree. She's a pharmacologist, and she writes books and writes scary websites online and goes to speak at a lot of conferences, and she teaches dumb information. Okay, this is from her website. She believes. Now, Dr. Wentz, she has I think she has a PhD in something now. So she goes by Dr. Wentz, even though she's not a clinician. She believes she can't put the most optional. She can't write the most optional because there is no evidence for it. She has to write, I believe, right? That should be a big, 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 big red flag. Okay. Supporters of optimizing thyroid labs have to rely on belief because the overwhelming body of medical evidence does not support those claims. Medicine's not religion. It's not politics. We have thousands of studies on the thyroid, and we owe it to our patients to interpret them and to teach our patients using the best evidence. And all of this thyroid optimization is based on very, very silly beliefs. This was pulled from one of her lectures. I went through it, so you don't have to. And some people find depression relief getting TSH levels between 1 and 2. Some people find depression relief by optimizing T3 levels. You know, if you treat 100 people stupidly and one gets better and 10 don't notice a difference and the remainder, whatever, 79 people are worse, who the hell cares that one got better, right? When people are picking and choosing scare studies from the medical literature, this is the sort of thing they have to rely on. Why is this dumb? And I'm just calling it like it is now. I just am really upset by this. I see people being hurt on a weekly basis, and I feel like dumb things should be called dumb. So there's where we are. TSH is not stable. So the proponents of this optimization kind of think it's a precision guided missile, and that right where the TSH is exactly where it is. But they must not have gone to a basic physiology course because TSH changes minute to minute because the brain is always scanning the environment. How much TSH do I need? Right? So minute by minute, it's pulsed out. It may go up and down, minute by minute. We know it changes over the course of a day. So we know hour by hour, there is 140% change over the course of a day. There's a bineural, whatever that word is, there's a two-phase circadian rhythm where TSH drops and then raises. So if you get your blood work at noon, right, versus 6 a.m., you're going to get different things, right? But people are being diagnosed with hypothyroid based on one single snapshot. Here's the craziest one. Did you know that the TSH will change on average 0.65 points over the course of a year? Now, for those people who are obsessing about tiny elevations in the TSH, 0.65 is way more. The natural fluctuation you'll get a year if you check in December versus you check in July is more than this tiny minuscule amounts that they're obsessing about, right? The body evolves with seasons. The body knows to change month by month, season by season. And TSH is not equal from a 20-year-old to a 30-year-old to a 50-year-old. It will naturally go up. And I just do not see any of these basic biologic facts being respected. I'm seeing 50-year-old women who naturally will have a higher TSH being treated the same way as a 20-year-old. It's really sad. So not only, and the last point here is that this 0.65 we know is significant because most cases of subclinical hypothyroid and hypothyroid, right, were diagnosed in the winter, right? When the TSH was at its highest, right? And we see this, this study was in Japanese adults. We see same pattern here in our hemisphere. Okay, so this is the study, PubMed 355-288-29. If you want to read it yourself, I think it's really important. All right, so I think I've hopefully given you an idea that people are making these big sweeping thyroid doses on a TSH that's not as accurate as they want it to be, right? But even if it were accurate, treating subclinical hypothyroidism is still dumb, right? This is just one of many, 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 many studies on the topic that just don't show improvement. So if you're going to do, we first do no harm, but if we're going to give a treatment, we want to know that it works. So this is a meta-analysis in 2015. So they took a bunch of studies, 5 of those studies, no improvement in quality of life. For the hypertensive patients, no change in blood pressure, no change in lipids, except for one outlier showed a 5% reduction, which is nothing, right? It doesn't do anything. You lipids go up 5% up or down. That really is not meaningful. So we are giving treatments. We're telling patients, oh yeah, you're going to feel so much better. It's a lie. Here's some more evidence. 737 adults with subclinical hypothyroid, so TSH up, T3, T4 low. They treated them, and they know it worked because their TSH levels dropped with treatment. No change in symptoms. No change in fatigue. It doesn't work. It doesn't help. Here we go. Among another study, among non-pregnant adults with subclinical hypothyroid, the use of hormone therapy was not associated with improvements in general quality of life or thyroid-related symptoms. Oh, your TSH is up, all that dry skin and constipation. We're really going to optimize this with a TSH. It's not true. It won't. That TSH is up. I know you've got those stubborn 5 pounds. We're going to put you on thyroid hormone and get that weight off. Nope. There is no consistent evidence that thyroid hormone treatment induces weight loss in obese euthyroid individuals, so those with normal T3 and T4. There is a little exception. If you have true hypothyroid, meaning your T3 and T4 are low, you are deficient, and you give them thyroid hormone, you will lose 0.8 pounds. 0.8 pounds is not a significant amount of weight. I think a lot of doctors still have it in their mind if the TSH is up or they have true hypothyroid and I put them on thyroid medication, they're going to lose 20 pounds. It's nowhere near that. In addition, it's probably just water weight. Water weight from electrolyte changes from the hypothyroidism, right? You have significant electrolyte imbalances and shifts when you have true hypothyroidism. You give the thyroid hormone and it's not making the metabolism work faster. You're not burning more fat. You are just rebalancing a fluid retention problem. If treatment just didn't work, a bunch of docs had this magical belief about TSH being a certain place and the T3 being at a 2.9 or whatever the doctor is, and it didn't work. And that was it. That'd be okay, right? They're taking a placebo pill. The pharmaceutical company is making a few more dollars. Maybe the patient feels better. But the problem is that it hurts people because the doctors are giving hormones and they are giving hormones people don't need, and the TSH is getting unnaturally suppressed. And when you unnaturally suppress systems of the body that do not want to be suppressed, you lead to side effects. So we have studied lowering the TSH below normal. So all the doctors who want to get the TSH below 0.05, and for those doctors who want to get it 0, they want to get the TSH undetected. We've studied that in a hyperaggressive malignant thyroid cancer. So this is not run-of-the-mill thyroid cancer. This is like the worst 5 to 10% of thyroid cancer cases. In those cases, doctors will, as a last-ditch resort to maybe extend life a few months, completely suppress the thyroid gland with hormones to try to prevent reoccurrence of the malignancy. And when they do that, it leads to big-time symptoms, right? So this is a study of those patients with metastatic cancer given high doses of thyroid to drop the TSH. Okay, what does it do? Gives them osteoporosis, fracture, cardiovascular disease, atrial fibrillation. These are big harms, particularly when People are being given unnecessary hormones for their entire life. Women who are fatigued, who are at high risk for atrial fibrillation, which causes strokes, and osteoporosis, which causes sometimes lethal hip fractures or horrible life-altering compression fractures. If you are increasing that risk of those conditions, you are hurting your patients. So this is why I get so passionate and angry about it. It's hurting people, but people are just religiously like zealots, just following along with something they heard. A lot of times people are giving hormones because they see antibodies. And I want you to know that positive thyroid antibodies does not mean that there is a horrible autoimmune condition all the time. Small amounts of antibodies are normal, right? So up to 20% of women are going to have anti-thyroid antibodies without any disease. It's just normal, right? And so that's 1 out of 5, 1 out of 4, perhaps. So when we get antibodies, what we don't want to do is say, oh my God, you have Hashimoto's, you have Graves, everything is going wrong. You need to be gluten-free, dairy-free, soy-free, all these vitamins, superdose high thyroid hormone, all the selenium, all the thyroid support. We need to take a step back because patients are coming in tearful, afraid, changing things for years, right? I get worried. I have slight concern when the TPO gets over 500 because I know if the TPO stays at 500, then there is a chance that the thyroid gland will eventually just crap out, right? There's more ongoing damage, and that patient may become irreversibly hypothyroid, right? So I want to tone down the concern about what antibodies we're seeing. And so I'm seeing people come in with a TPO of 30 and they're being read the Riot Act, right? You are gonna get thyroid cancer. Everything is terrible, right? 30, this is autoimmune disease. You get one autoimmune disease, you're gonna get another, and it's just not based in reality. I would like to. This is a paper that I was able to contribute on a few years ago, and the main argument that we were making is that a lot of the general symptoms that are put forward as thyroid, the constipation, the dry skin, the gut, the fatigue, the brain fog, those can all be from thyroid, but they can also be from the gut. And in my experience, treating the gut is the single best thing you can do to make the thyroid happier, right? And because the symptoms overlap so much, instead of just throwing people on hormones, perhaps we can work on the gut. Because the GI dysfunction is 45 times more common than hypothyroidism. So why would we just start by throwing hormones when we can alter the gut? And the chance of you getting a successful outcome is so much higher fixing the gut. All right. Hypothyroidism, 0.3% of the population. IBS, 15, right? The symptoms overlap. So why don't we treat the gut first? And everyone here knows the health of the gut is not just about the gut, right? It's about the nervous system. It's about the immune system. It's about bone health. It's about muscle health. It's about brain health. And so it's just a more elegant solution. We also know that when you treat the gut, you get better thyroid function. And here's a study. You can eradicate H. pylori in symptomatic patients. You can change the T3, T4, and you can improve you can treat the gut and improve the thyroid labs. Here's another one. Hypothyroid patients treated with probiotics saw decreased TSH levels, less fatigue, and needed a reduced levothyroxine dose. I see that all the time. That is very, very common. You treat someone with the appropriate diet and probiotic select, Saccharomyces boulardii, Bacillospore select, or equivalent supplements, and you see the TSH improve and people are on less levothyroxine because partly they're able to absorb the thyroid medication better, but partly because the underlying causes of the thyroid dysfunction gets treated by the probiotics. Okay, we've made it to a case study. Give me a moment to take a sip of tea. Okay, so this was a 33-year-old female. She had been previously treated by a world famous thyroid doctor. And she came to that doctor with fatigue and GI symptoms. And the GI symptoms, gas, bloating, constipation, diarrhea. This is IBS, this is SIBO, this is bread and butter for our practices. But the world famous thyroid doctor heard fatigue and said, well, I have a hammer and you are a nail. So I'm going to hit you with this hammer for a couple of years and hopefully I will eventually get you better. She was diagnosed with suboptimal thyroid levels based on perfectly normal labs. That is wrong. You could say it's malpractice because these are normal labs and suboptimal thyroid function is not a diagnosis, right? Multiple dose changes over years. Every time world famous thyroid doctor gave her a new formula, she felt worse. She came to see me for a second opinion, and I did the things that we do. I gave her a diet she could follow. I gave her broad spectrum probiotics and I gave her magnesium for her constipation. Everything was better in 1 month. This is the sort of thing that we need to be shifting towards. This is the sort of thing everyone here can do. We need to de-emphasize the importance of the thyroid. We need to re-emphasize treating the root causes of this, which is so often in the gut. And so that's where I'll end this little case study with. And I think I'm doing pretty good on time so far because I got all pissed off and spoke quickly.
Thank you,
All right.
Dr. Mather.
Yes, sir. All right.
Well, I'm going to start out the chat with a couple of controversies. Get the ball rolling here.
All right.
Um, this is very recent. I got a frantic call today from one of my customers. For better or worse, had been using Armor Thyroid for several years. Yes, Marilyn, you're right. FDA has very recently come down on all animal-based thyroid medication, not just Armor, Thyroid, all of them. And my understanding, as of October, they're going to be unavailable. That's officially, of course. You may not be able to get it at CVS, but I'm sure there'll
You
be
can have it
other
compounded.
other sources you can find online, I'm sure. But the FDA is coming down on that. Uh, and so she's very frantic. Dr. Mather, my first question to you
Yes.
is, what are your thoughts on that? Is this a good thing or a bad thing?
I think it's a good thing because the reason that they are taking these formulas off is that there's not enough consistency in the ratios of T3 to T4. And I think we expect a certain degree of accuracy on how much of a substance is in a medication. And if they can't say that batch to batch there's consistency, then I think it's problematic. My other perspective is that most patients, if you line up 100 people with true hypothyroid, most people feel better just on levothyroxine Synthroid, which is synthetic T4. There are a small number of people, but the minority who feel better on a combination product, but it's not the rule. It's not everybody. And so I think from a public health standpoint, we keep the prescription of T4 and we can always add T3 as cytomel by a prescription. And then for this very small number of patients who need yet a different approach, you can compound. So personally, I'm okay with getting rid of Armor and Nature-Throid. I know that is very abnormal for functional medicine doctors, but I'm seeing all of the harm come in. I'm seeing years of worry from people having to say, oh, well, Nature-Throid went by and I used to be on NP and NP worked fine and it was Armor. And so much of those, I respond to this, but I don't respond to that, is I think due to fluctuations in the dose. And so I think in the long term, this will make things easier and better. It's going to be, I, it's going to be a real big headache for the doctors who've been obsessing about thyroid labs for their whole career.
Thank you. My second, how can we possibly talk about the thyroid without talking about the iodine controversy?
All right.
High dose, low dose, where do you stand?
We are in the United States, and if you look at the soil of the United States compared to a place where I practiced for a year in New Zealand, we have much, much, much higher levels of iodine, and true iodine deficiency is rare in the US. Whereas when I practiced in New Zealand, it seemed like every 1 out of 20 people had a freaking goiter because the volcanic soil of New Zealand is very deficient in iodine, as in zero. So like where we supplement like folates in breads, the same thing goes, the New Zealand government will give iodine pills or iodine droppers. And so here in the US, it's not a concern. We do not need huge levels of iodine. If anything, a little bit. I think there's an argument out there that if you're eating more processed, if you're eating more whole foods, you might need more iodine because you're not getting some of the extra supplemental iodine. I don't give iodine in my practice at all. And I find people getting better. But I do see a couple times a year someone coming in who's self-experimented with iodine and they now have hyperthyroid. They have really jacked up their thyroid with iodine, and that can take months to unravel. And so, from my perspective, I see the harms of high dose iodine, and I just don't think it's necessary in most cases to give iodine. So that's where I come from.
What would you say to those, and you know who they are, we won't name names, we all know who they are, who are obsessively passionate about 12 milligrams a day, 20 milligrams a day, 50 milligrams a day, and say they're basically transforming their patients' lives? What would you say?
I would say there's a lot of things in medicine that are pebbles. And what I'm trying to teach people to do is focus on the boulders, right? You're trying to go somewhere and there's this whole bunch of boulders in your way. And these people are just like walking around right here being like, well, there's a pebble here and a pebble here, and they don't get anywhere. And so I would have a very hard time believing that they're getting those results. Maybe there's 1 out of 100 people that found their clinic and they needed the iodine, but I think as a general rule, that would be a very bad idea to be really focusing on that much iodine.
Thank you, Dr. Mather. And let's now go to the chat. You pull it up here. Okay. Here we have from Dr. Perlman. We need to find the cause of abnormal thyroid function, and something you didn't talk about, genetics, genomics, in addition to what you did talk about, diet, toxic load, etc. Any comments on genomic connections with the thyroid?
I don't know of any on the top of my head. I'm sure there are. We know for sure that some of this is inherited. You'll see families with higher incidence of thyroid disease. So without a doubt, there is genetic components to this. I just don't know a practical way of saying, okay, we've got SNP X, Y, and Z, therefore I should treat this differently. Because from my perspective, even if you have a genetic SNP tendency towards more thyroid dysfunction, still need to treat the gut. And you can't really control um, the gun, right? But you can control the environment that's going to shoot the gun, right? So for me, it's get the gut. You're going to do the gut no matter what, and see where you end up. And so I don't do very many genetics at all in my practice because I think it often leaves patients and providers more confused than when they began. I don't personally feel like I've seen enough of them, with a few exceptions, that if I get a genetic test, it's going to make me change my treatment in one way or the other. And I I I worry that people who do the genetic testing tend to come in self-identifying with their genes. They'll say, I am MTHFR. I have an MTHFR variant. I am COMT. And they just start developing these belief systems about how their cells work that I think are pretty far detached from actual clinical results or their day-to-day functioning. Because you can have a SNP that's off that is just not on, right? Epigenetics can turn off or on different genes, and you've got multiple copies from mom and dad of most genes, just because you have one of them, your body could just be saying, oh, well, that gene doesn't work well, so we're going to downregulate that one and use this one. So for me, epigenetics, I don't think it's prime time yet. I think we're still in the learning more stage.
Thank you. Let's move on here. Dr. Perlman, thank you very much for purchasing the subscription. Appreciate your supporting NNS.
Oh, all right. Nice.
And let's see. Here's Marilyn's full comment that I commented on briefly. Armor and maybe Nature-Throid may not be available in compounded thyroid meds, also because the old research has to be redone, and the time to do so will not be done in time for the deadline sometime in 2026. What is one wanting the T4 and T3 on low-dose armor area to do? So now what do we do? For these people been on armor, they can't get it. What do we do with these people?
Well, here's how I would approach it. First, you need to say, did this person have a real diagnosis of hypothyroidism? Yes or no? So, did they have their thyroid glands surgically removed? They're not producing T3 and T4. They absolutely need hormone support, right? Did they have a thyroid ablation, right? Did they have their thyroid radioactively ablated? Or have they have advanced autoimmune disease or thyroid cancer where they will need supplementation with hormones? If that's the case, then you keep them on hormones, right? Without a question. And if they're on T3 and T4, you substitute Armour Thyroid with a levothyroxine T4 prescription and Cytomel, which is T3, right? That's one thing. But what we now know is that 60% of American adults who are on Synthroid, who are on thyroid hormones, who are on Armour, don't need it. They were being given it incorrectly, and they can come off without any problem whatsoever. So my bias for patients who come into my clinic, if I think they don't need it, I have them stop it. Because 60% means I'm going to help more people than hurt by just taking them off. And the patients who are being given it inappropriately, they feel better. They're like, oh my God, that's why I had insomnia. Because that doctor told me I had low thyroid, so I was taking Armour Thyroid twice a day for 10 years. I slept for the first time in years. And you're just like, oh my God, right? So for me, the first question is, do you even freaking need thyroid hormone? Is this a good idea? Why are you on it? Have you ever tried getting off of it? Maybe since you've started it, you've actually began exercise, or you're not living in that moldy house, or you fixed your gut. Odds are you don't need it. But some people who are on thyroid hormone need it. And so you have to be open to being wrong. So if someone is stopping their thyroid hormone and their thyroid is not ready to produce hormones, that 40% that aren't going to come off it well, you need to restart it quickly, because patients who need thyroid hormone, they stop it, they feel like they got hit by a truck. It's like depression. They're crying. They have no energy. They can't get out of their bed. Everything hurts. They're a disaster. They're like very sick, and it's not a question. So if you stop the thyroid hormone, you're like, I think I might have had a little more bloating. Maybe, or maybe Tuesday I had a little less energy. That's not it, right? You're looking for big fluctuations. And if you don't notice a difference off of it, odds are you didn't need it to begin with.
Great, thank you. Let's move on here. Let's see, Dr. McFarland. Dr. Joe, thank you for your passion. Thank you for that nice
Thank you for listening to my ranting.
Yes. And here we have from Dr. McKenna. If someone is on Armour with suppressed TSH, what is the process for coming off Armour? I think you just talked about that, Dr. Mather.
I just stop it. I mean, I've been doing thyroid stuff for a long time, and so I'm pretty comfortable. I just have people stop it. If I think they're being given it wrong, I say, look, I think that someone made a mistake. I think there's a very good chance you don't need it anymore. Maybe you needed it before, but odds are you're not going to need it forever. Let's try off. And if I'm right, you're going to stop it and you're not going to notice anything, or you're going to notice less anxiety, agitation, palpitations, and you're going to sleep better. If you feel worse, restart it. If you're not sure, I'm going to write a lab and go check your TSH and your free 3 and your free 4 in 2 weeks or a week. And so I think you give them kind of pathways for what to do if they feel better, worse, or they're not sure. And most of the time, you just stop it and they either feel better, they don't notice a difference, and they'll love you forever for taking them off a med they don't need to be on.
Great. Another comment from Dr. Perlman. Thank you for your passion.
Hell yeah.
Yeah. And here we have from Larry now. If someone was given Synthroid more than 10 years ago due to TSH around 12, with low normal, free T4 and free T3 now,
That's the exact
can
definition of
appropriate diet and
subclinical
nutrition
hypothyroid. Yep.
can appropriate diet and nutrition based on their specific issues, gut issues, etc., can they slowly decrease and eventually get off thyroid replacement hormone over time? Now, he's talking about
Yes.
situations where the free T3 and T4 is low.
Low
Can we
normal.
get them off
Low,
medication with lifestyle changes? It's
low normal free 3.
low normal, free T4, free T3, and a TSH of 12.
So I would say yes, they can get off it. They're more likely than not they can get off it if they're working with you, Larry, and you know how to help them with diet and probiotics and addressing any other root causes in their lifestyle, toxin exposure, sleep that are being missed. So more likely than not that they get off it, more likely than not that they don't need it. And absolutely, I think there's a very, very good chance they should get off of it. And I would put it to them like, I've seen other patients get off of this. I think you can get off it. Let's try. We're going to get your body as healthy as it can be in the next month. And I want you to do A, B, and C. Then I want you to stop it. And then 2 weeks later, get your labs. If you still need it, I'll prescribe you the med. And give them that kind of goal. And, you know, they'll jump through all the hoops to try to get off the medicine and they'll love you. And so that's how I would do it. And yeah. You know, people make it too, I think that people make it too complicated too. With, okay, well, you're on 125 of this, and then we're going to go to 100, and then go to 88. Just stop it. The body's strong. It'll make hormones if the thyroid's in a good place.
And here we have a question from Marilyn. Can you take low-dose thyroid not every day if T3 is low and T4 is on the low side?
So doctors do all sorts of silly things. For whatever reason, I see weird things with thyroid. I see take 100 on this day and 88 on this day, and then 100 on this day and 88 on this day, or 75 3 days a week, or this off and on. You can do a lot of different things. I think the problem is in people expecting that if you micromanage the T3, they're going to get better outcomes. That's the problem. The problem is not what dose, it's over-promising or thinking that once the T3 gets to a certain place that everything is going to be great. It doesn't work like that. And the other thing is that I think for all of the doctors who get so pissy about how they think there's an optimal range that they've made up and that their optimal range is better than everything else, but they say there's bio-individual variance. Well, the truth is that some people have a normal TSH and their T3 and T4 are always just slightly low. And they feel fucking fine, right? Why do they need hormone? They feel great. Like everything is fine. And their T3 is a little bit below normal. Well, they've got bio-individuality, right? Why can't they not need hormone? It's like they want to give hormone for everything. They want it to be the answer. So it's heads I win, tails you lose. And they want to have it both ways. So I think the problem is obsessing about T3. So if you find, like, for example, a low-carb paleo diet, there are a couple studies where you'll see T3 and T4 drop, right? Low-carb paleo is pretty freaking healthy, right? But when you see that, but the thyroid hormones are dropping because the body is different. The metabolism is different. Maybe the body just doesn't need that much thyroid circulating when you're doing other things well. And so, right? So why obsess about, tiny little fluctuations if people are feeling good?
Now we get, Marilyn has another question, getting into kind of like the iodine situation, dietarily, use of kelp or seaweed.
Yeah, that's the sort of thing I think is awesome, right? Particularly the kelp and seaweed, because my understanding is that it's not just iodine you're getting like vitamin K2, which no one gets enough of, right? So it's just not in our diet. So when you're adding things that are, outside of the norm dietarily, that's awesome. The body knows how to deal with if it sees a little bit too much iodine or whatever micronutrient in the kelp or the seaweed, They'll take what it needs. It's not the case when you take a bomb of iodine in and your body's like, oh boy, ought to do this. Right? So kelp and seaweed, go to town. That's great. I love it. Um, yeah, we should be trying to manage our micronutrients with diet, not supplements.
All right, we have another comment here, a question from Marilyn. Can taking thyroid for a long time shut the thyroid down?
You know, it would make sense that it could, but I mean, I've had patients on thyroid for a decade and I stop them cold turkey and they're fine. So I don't, everyone's a little bit different, but particularly when people are being given the hormone in a place where they didn't need it, and it's, they're taking 150 of levothyroxine for years and years. I, I think that you can just stop it and see, as long as you're checking the labs and you're talking to your patient and you're following them and you're on their side, I just try it. I don't think I've ever seen a case where someone was given thyroid hormone and they just needed it forever after when they were diagnosed inappropriately. Some people have true hypothyroid, right? So we saw that 8%, right, had hypothyroid and they were appropriately given medications. Those people, their thyroid's not working, right? So they're going to be on thyroid meds for decades. And if you stop them, they will tell you because they'll feel awful, awful, awful. And so their thyroid was shut down. But I don't think the thyroid in and of itself will turn the thyroid off.
All right. We have a nice thank you from Michael for clear clarification.
You are quite welcome.
And last one, Marilyn says, love Dr. Joe Mather's common sense approach. So, and I couldn't.
We all have to do some work on fixing some of the silliness in our field because our patients are hurting.
Yeah, yes, I couldn't agree more. It's always nice to talk to somebody. You're right. We often hear about the theorists and the time we're spending more time in the library than in the clinic. And it's nice to hear from somebody who's deep like you in the trenches. And really appreciate it.
It's interesting to think about how some of this kind of perpetuates. You have people lecturing, and in a lecture you can't give all the clinical context. You can give a little vignette and a couple studies, and people can reach the wrong conclusion based on a couple little sentences. The other is that I think a lot of this crap medical information is just being passed around on Facebook and social media platforms, and doctors are eating it up. They're not skeptically looking at the information. They're like, oh, that seems reasonable. And doctors need to do better, right? It's really nuts. We got to be a little bit more skeptical about the things that we're reading, and then when we see things that are wrong, I think we need to speak up a little bit.